And now it's my pleasure and honor to introduce Professor Roberto Orecchia, Professor of Radiation Oncology at University of Milan in Italy. Professor Orecchia will talk about radiotherapy guidelines after neoadjuvant therapy.
Good evening. Thank you, Mr. Chairman. Okay, my role is to speak about some guideline after neoadjuvant therapy, but frankly speaking, so while we have a clear guideline after breast conserving surgery, while we have a clear guideline after mastectomy, or quite clear, there are no specific guideline in this setting. And this is mainly due to the fact that obviously the picture of the patient, the picture of the disease is changed after the neoadjuvant treatment, and also the situation, if we consider for indication to radiation therapy, the stage before, at the beginning of the history of the patient, or after the reduction of the disease. So, as I said, we are following recommendation about mastectomy. I will focus my talk in a more locally advanced case or high-risk patient. And the rationale of the use of post-mastectomy radiotherapy is listed here. And we can consider that about from 20 to 30% of the people are considered a high risk. In this case, radiation will be recommended to help to reduce consistently this risk up to 70%. For example, 30% risk may be reduced by post-mastectomy radiation under 10%. And normally, the radiation treatment is given to the area where the breast used to be, and often also to the lymph node region nearby. This is the last published recommendation about post-mastectomy radiation a few months ago from the St. Gallen Consensus Conference in Vienna, really. But the panel suggested that following mastectomy, radiation therapy should be standard for patients with tumor size of 5 centimeters or greater, those with a positive macrometastatic sentinel node biopsy, but did not receive axillary dissection. And this is new, quite new. And also for patients with 1 to 3 involved nodes and adverse pathology. So we have a magic number that is at least 4 positive. Node in the axilla means yes for radiation therapy, less no, and now some data changed this feature. What means is exactly adverse pathology is not still fully defined, can help in defining the risk. The recent publication of this study, MA20, in which has been treated in a randomized study patient, great majority of patients, 85% of the patient affected with 1 to 3 positive lymph node, also small percentage of patients with a classic indication, and also patients with lymph node negative but other risk factor that are listed here, like grade 3 histology, negative disease, and lymphovascular space invasion. In this study has been shown that there is an advantage in the extended the treatment to the regional area, the regional node area, and you can see there is a statistical significant advantage both for local control, local regional control, for distant disease-free survival, and also distant disease-free survival. There is a price to pay in order to extend the field of irradiation. And this price means a little bit more incidence of lymphedema and also a little bit more incidence of grade 2 or more skin toxicity or lung toxicity. The main question that we have to face when we see and we have to decide if indicated or no radiation therapy, if after neoadjuvant chemotherapy or neoadjuvant treatment, we have to consider the same recommendation made for the patient who receives surgery as first treatment. As I said, there are no available data from mature randomized clinical trial. There are several historical trials, institutional trials, but not a clear comparison based on the high level of evidence. And what is important, it is important to extrapolate the subgroup of patients that after neoadjuvant treatment and surgical reconstruction benefit from local regional radiation therapy, but the broad spectrum of stage made the failure risk assessment somewhat confusing. What is clear, since the first experience published, strong contribution from the MD Anderson in Houston since 2004, Dr. Wang paper, in which has been demonstrated in the whole series of patients treated after neoadjuvant treatment, the rate of local control was statistically better using irradiation, postoperative radiation versus no irradiation. You can see this data that has more than 10 years ago has been confirmed also in other several studies, and you can see also that more recently, up to the past year, the advantage in giving post-mastectomy irradiation on the local control, local regional control is clear, and is also important from the statistical, significant from the statistical point of view. And we can say that in summary, looking in the literature, the radiation therapy reduced the 10-year local recurrence rate from approximately to 30 to 10%. This is exactly the same for the patient who did not receive any kind of neoadjuvant treatment. And what is important is the same feature for post-mastectomy again, is associated also with improvement of about 9% in 10-year overall survival. There is an attempt in the literature to identify if you can select the patient and to avoid, in some circumstances, the treatment of the patient. This is analysis in which has been identified some prognostic factor, both for local regional failure or also when it impacts on breast survival, specific survival. You can see that stage and age of the patient, pathological stage, are important, also the number. But what is important is also the cumulative effect on more than one factor. In this paper, you can see that if you have two or better three or more negative factors that are listed in the red square, you have a very high risk of local failure with respect. So it may be just a criterion in order to individualize the indication. With respect to survival, there is also, of course, an impact in any stage of the disease. You can see huge difference in 3B and 4 stage, and also for tumor staged as T4, and also an impact in the number of lymph node with 4 or more lymph node with respect to less involved lymph node. One of the major questions is when the patient at the surgical specimen has a clear axilla after the positive axilla before the neoadjuvant treatment. There are few data on the role of radiation therapy. What is clear that if the axilla of the patient remain positive, there is a clear advantage in giving post-mastectomy irradiation. There is also a trend in case of a negative axilla. Other prognostic factor has been identified in the B18 and B27 study, and this also helped in order to select some subgroup of patients. At the end, one of the last recommendations is 3 years ago. This group, International Consensus Conference, the European group and the American group, and in which has been suggested that after neoadjuvant systemic treatment, in case of surgical conservation of the breast, of course, the treatment is indicated exactly as in case of not neoadjuvant treatment. But also has been stated that, what I tried to say before, that normally we consider that in general the indication to radiation therapy is guided by the initial clinical stage, by the pathological find at the time of surgery. And what is recommended here is indicated for all node-positive patients and patients also with locally advanced disease or inflammatory breast cancer. And also suggestion is not clear of today is that additional studies are needed on post-mastectomy radiotherapy in node-negative patients after neoadjuvant. Another attempt in order to define if you have some subgroup of patients in which post-mastectomy radiation can be avoided differently from normal or conventional indication after the simple mastectomy. And this experience with the Delphi method that has been published in 2013 tried to identify a low risk of patients, that about 10% of the total, in which post-mastectomy radiation can be avoided. The condition is to have early clinical stage, age more than 40, positive disease, estrogen receptor positive disease, partial pathological complete response or minimal involvement of the axillary node, and also without lymphovascular or extensive component. But only if all the factors are combined, according to this suggestion, we can avoid radiation therapy. We have to do the radiation therapy in patients instead, so high risk, sorry for the error, is high risk, advanced stage or pathological clinical stage, young age, triple negative disease, no pathological complete response in primary tumor, again with lymphovascular or extensive component. And in this case, the radiation therapy suggests that even only one of these factors is present. St. Gallen, not in the last, but in the past meeting, try also to consider that in some selected cases, for example, patients with luminal A who receive this kind of treatment, but I don't know, I'm not sure that is indicated to receive neoadjuvant chemotherapy in this case, but can be also saved by the treatment of radiation therapy. Just to conclude, very recently, my colleague and friend, Jacques Bernier from Geneva, has published this very comprehensive review about the role of post-mastectomy radiotherapy after neoadjuvant, and this is the conclusion that in which I fully agree. Following neoadjuvant chemotherapy, post-mastectomy radiation has to be delivered selectively. Patients with locally advanced disease, especially with incomplete response in T on N, should be irradiated. Patient aged more than 40 years with stage 1 or 2A and R positive do not need post-mastectomy radiation when pathological complete response has been achieved. And the use of the omission of post-mastectomy radiation in patients with 1 to 3 positive node in the axilla remain poorly defined. But as I said before, there is a general trend to increase the use of radiation also in this intermediate risk of the patient. Can we further tailor radiation therapy in the next future? There are some, finally, some study that are still ongoing. This is an example of this study in which probably the result will help in order to clarify the value of local regional radiation therapy for patients with positive axilla that became node negative after the neoadjuvant treatment, but who have to wait for this data. Probably the future, as my previous colleague speaking about lack of guideline in hormone therapy, in neoadjuvant setting of hormone therapy. The same probably our effort should be in order to identify using more extensively radiogenomics. Radiogenomics is very useful not only for prognostic and predictive factor for the patient, but also to assess different parameters related to the sensitivity of the patient, both of the tumor or normal tissue of the patient to radiation therapy. And now there are some preliminary very interesting studies about the capability to predict the radiosensitivity of the breast cancer, to predict the radiosensitivity of the normal tissue, and of course we need to have in clinical setting also some prognostic tests in order to identify patients who might need intensification, some case, or reduction, or maybe also omission of radiation therapy. Just an example of what I said, in which has been under validation and under development some gene profile assay in order, for example, gene expression. This is a study based on the study on the Danish trial, very historical trial, in which this kind of gene profiling is really able to select the patient that can benefit from the use of post-mastectomy with respect to the omission of post-mastectomy. And the same also seems that the impact of some other gene profiling signature may be also independent factors for prognostic, for local regional, and for also for survival of the patient. This probably is the opportunity for the next future. Thank you very much for your attention.
Thanks a lot, Professor Roberto, for the informative, illuminating talk. And unfortunately, we have run out of time. Maybe we can have just a few questions.